Hi, my name is Melissa Howdeshell, and this is my Migrant Farm Worker Fieldwork Observation presentation for Nursing 583. So I'd first like to talk about the sites that were selected for my project. Sites were selected based on the receptiveness of the contacted agencies and farms. My first contact was the Piedmont Migrant Farm Worker Agency. That is located in Prospect Hill, North Carolina, about 45 minutes from where I live. Brian Parrish is the outreach coordinator for this agency, and I contacted him via email. Brian informed me that in central North Carolina, migrant health care clinics are not operational until the workers arrive, which is around early April for central North Carolina. He suggested I contact agencies closer to eastern North Carolina for assistance with my assignment. In the meantime, I contacted the Early Farms. Early Farms is locally owned and operated farm that I became familiar with because of their strawberry fields. Trey and Aaron Early currently run the operational side of the farm, and were excited to have me come to the farm over a 2-day visit. The first day on the farm, I met with the Earlys. I toured the farm and talked with Mr. Early regarding the aspects of migrant farm workers and involvement in the H-2A program. The second day was spent meeting one of their long-standing workers, Fernando, and observing his role on the farm. During my time with Fernando, we talked about my assignment, my goals, and some of the difficulties I had been having. Fernando offered to introduce me to a family he was friends with, the Rodriguez family. The Rodriguezes are undocumented residents who work on a local dairy farm in Stokesdale County, North Carolina. Throughout late February and March, I was in contact with members of Robeson County and Benson, North Carolina division of the North Carolina Farm Workers Project. I had wanted a large portion of my project to encompass direct patient care, especially since I'm a nurse practitioner student, and I knew I needed to focus this project on the healthcare aspect of migrant farm workers, and also because that's mostly what I was interested in. I had 3 separate appointments set up to observe and participate with mobile clinics for migrant farm workers. However, for various reasons, unfortunately, all 3 of those clinics were canceled. And unfortunately, no additional clinics were scheduled in these areas prior to the conclusion of this assignment. So the remainder of my project was completed at Wilson Tree Nursery in Snow Camp, North Carolina. This site was suggested to me by Fernando because of the differences that he personally knew of in regards to working and living conditions. The expectations and goals of my field work were to observe and draw evidence of some of the disparities that we have discussed this semester, to determine what resources are available for migrant farm workers for future reference, and to expand my personal knowledge of the Hispanic Latino culture, especially in regards to culturally competent interactions. My first day at the Early Farms was spent with Mr. Early, taking a tour of the farm and getting an overview of the 800 acres that they own. The farm was originally established in 1973 as a tobacco farm, and it remained as a tobacco farm until 2004. During the time that it was a tobacco farm, the farm utilized over 25 migrant workers yearly. With a decline of tobacco needs, the Earlys transitioned to livestock feed crops, mainly soybeans, wheat, and barley. The Earlys currently hire 3 H-2A migrant workers yearly. One of those workers, who I mentioned earlier, and I'll talk a little more in depth about on the next slide, Fernando, has been with the farm for the last 15 years. The other 2 workers have been with the Earlys for at least the last 5 years. So I asked the Earlys about the demographics of their workers. The youngest worker that they've ever had was 17. The oldest was 62. And Mr. Early chuckled and said that the 62-year-old worked a lot harder than the 17-year-old. So based on the information that we had discussed this semester, I was interested in interviewing the Earlys about their interactions with the workers, the environment of the farm, the conditions of the living spaces. Mr. Early informed me that the Early Farm is a Gold Star farm. That indicates that all of the requirements for migrant farm worker accommodations have exceeded minimum standards. Based on this, Early Farms is not required to undergo yearly inspections by the Department of Agriculture. However, they choose to continue the inspections to make sure that they have their I's dotted and their T's crossed. And just for my personal information, I asked Mr. Early to kind of review some of the H2A program with me, simply because I didn't know a lot about it. Even though I know we briefly talked about it during the semester, I kind of wanted to have more in-depth information. And the picture on this slide is actually Early Farms at sunset. That's a picture that they took. I did not take that picture. So the H2A program is a temporary program to provide agricultural employers with anticipated shortages of domestic workers, non-immigrant foreign workers, to the U.S. to perform agricultural labor or services of a temporary or seasonal nature. So 45 days prior to the arrival of the workers, the farm sites and housings must be inspected by H2A inspectors. Details inspected include electricity, running water, hot water, insulation, appliance functionality, HVAC, smoke detectors and fire extinguishers, and intact screenings on windows and doors. Violations result in workers being denied. Unannounced inspections can occur at any time, and violations in housing requirements are subject to fines. Early Farms has only had one unannounced inspection since 1973. A neighboring farm remotely failed an unannounced inspection, which resulted in a $25,000 fine, Mr. Early shared with me. So they take migrant farm worker accommodations and violations of housing requirements very seriously, at least in the area where we live, in Guilford County, North Carolina, which was pleasant to hear, especially given some of this information that we've seen this semester based on the research that we've located through internet searches. According to Trey, farms who utilize contract workers and not H2A workers have higher prevalence of housing violations. However, in Guilford County, the presence of agricultural inspectors is high, and there have been no reported violations in the last 5 years. Memberships to the H2A program is not cheap. There's a $1,000 joining fee and a $1,000 fee for each worker that is requested. This is in addition to the pay that each worker is guaranteed. Safety training is conducted and completed by the H2A program in Bass, North Carolina upon entry into the state. This removes the burden of inadequate education from the farm owner. Farm owners are required to display safety information in dual languages as well as provide safety equipment. H2A provides transportation from Mexico to North Carolina and return. The workers are required to pay the visa fees for entry into the country. Workers are guaranteed a minimum of 30 hours per week at an hourly rate of $10.85 an hour. Overtime is not paid. H2A workers must sign a disciplinary contract upon entering the program, which states that they are not to report to work under the influence of alcohol. Should this occur, or should the worker return to Mexico after the stated return date on their work visa, they are blacklisted from the H2A program. Farm owners are required to provide workers' compensation to all workers, so this covers any work-related injuries that may occur on the job. Health insurance is not provided. Owners are required to provide transportation to medical facilities should a worker request treatment for a non-work-related injury or illness. And Trey and Aaron Early shared with me that they have never had a work-related injury on their farm. Mr. Early also shared with me this interesting fact that I included at the bottom of the screen from last year. So last year, there were 175,000 H2A positions available in the United States. U.S. citizens take precedence over migrants for placement in these positions. So last year, there were 150 U.S. citizens who applied for H2A positions. Of those 150, only one individual remained employed with H2A for the entire crop season. So now I wanted to take a little bit of time and talk about Fernando. Fernando has been working with the Earlys for the last 15 years, as I mentioned. Fernando is a father of 4 and a husband. His oldest daughter is currently enrolled at the University of Texas as a sophomore. Previously, Fernando owned a small store in his hometown of Chihuahua, Mexico. The number of gangs dramatically rose in the area, and his store was ultimately taken from him by gang organization. Fernando opted to cut his ties with the store for his family's safety. When asked about his goals for the future, Fernando plans to return to the U.S. as an H-2A worker until he can afford to pay for all of his children to go to college. He has no intentions of ever moving to the United States. His accommodations on the early farm are better than those of many in Mexico. Because of the money that he has earned through the program, he states that he's considered higher class than most in his town. Fernando is acculturated well to the American culture. He is fluent in English. He has developed relationships and friendships that have stood the test of time in the U.S. In the trailer Fernando stays in, he has DirecTV, he has a cell phone, he has his driver's license, and he has a car. He knows that as long as he's with the Earleys, his life in the U.S. will be good. He says the work is hard, but it's fair. He states, the Earleys really care about me. They call me in Mexico before the season starts for my birthday, and they call me at Christmas. They aren't just my employers, they're my family. When asked about health care, Fernando laughed at me. He states that he doesn't believe in health care like in the U.S. He can't recall the last time he ever had a checkup, or if he's ever had a checkup, to be honest. When he's sick, and he says really sick, he uses the emergency room for treatment. He's only done that twice in the last 15 years. One time, he went to the emergency room for a bad cough, and the physician told him his blood pressure was borderline high. He had an appointment scheduled for a follow-up clinic for the following week, which he said he just never even bothered thinking about, and he has not followed up on it since then. He feels that he's very healthy and he does not need to see a doctor. He says doctors are for when you are sick. When he has a cold, aches and pains, or anything else, there's a local Mexican grocery store that has a pharmacy close to the farm. Fernando says that you can get antibiotics, narcotics, sedatives, muscle relaxers, anything that you can need a prescription for, you can buy there with no prescription. When I asked him where the store was, Fernando laughed at me and said, if they saw you coming, they would close the store. So being that Fernando had not had any preventative care, and the student nurse practitioner student that I am, I decided to do a little physical assessment of Fernando. And he begrudgingly obliged my antics. So the main thing that I noted on Fernando's assessment is that he still remains to have elevated blood pressure, with his blood pressure being in the 150s over the 80s to 90s. So I provided him with some general health education, especially given the increased risk of cardiovascular disease in Hispanic. And I encouraged him to consider follow-up, to which I pretty much just got a chuckle. But of note, he is a non-smoker. He does drink alcohol occasionally in moderation, but he does have a poor diet. He says mainly processed food and fast food when he gets a chance to get off the farm and eat. So I thought this was an observational experience, and Fernando told me that I had to pay for my time with him. So this is the greenhouse that Fernando is working in currently with the Early Farms. They are seeding plants for the upcoming season. And so you'll see over on the picture on the right, those are little seedlings that we were filtering through and picking out ones that were dead and lining them all up in this greenhouse. So this wasn't necessarily just an observational experience. I had to earn my way with Fernando. So Fernando introduced me to the Rodriguez family. After spending some time with him, the Rodriguezes came to North Carolina as undocumented residents, and they have worked on the dairy farm that they live on for the last 18 years. They have an established relationship with the owner of the farm, and they feel that their employment has been a good experience. The Rodriguezes have no intentions of returning to Mexico. However, the older family members have no intentions of becoming U.S. citizens. They say there's no point. That was the theme of the conversation with Jose, who was the grandfather, and Maria, who was the grandmother. The older individuals, Jose and Maria, use Mexican medicine and herbal therapies. In fact, Jose returned to Mexico several years ago to have cataract surgery. He had looked into having cataract surgery here in the United States, but healthcare in Mexico is much cheaper, and he couldn't afford to pay what U.S. Physicians had quoted him for his cataract surgery. Jose has hypertension and diabetes. He attempts to control both through diet. When coming to the U.S., he was on 1 blood pressure medicine and 2 diabetic medicines, but he could not afford the medications when he stopped taking them. His wife Maria is still taking her blood pressure medications. When I asked her how she gets the medications, she has them shipped to her from Mexico because it's cheaper in Mexico. And so she showed me the bottle. It was in Spanish. I couldn't even tell you what she was taking to even be able to give her any idea of just some basic general information or education about the medication. And unfortunately, my iPhone did not have reception where we were, so I couldn't even do Epocrates. The family had previous fears of deportation, mainly because they are undocumented citizens. However, they've been here for almost 2 decades, and they've not had any issues with law enforcement. So a lot of their fears of deportation have subsided. Rachel and Anna, who are Jose and Maria's grandchildren, are U.S. citizens. They have aspirations for college and bright futures, and they knew that becoming a U.S. citizen was a necessary step. Unfortunately, both of their grandchildren work part-time, and they don't have health insurance offered to them through their employers. When I asked them about the Affordable Care Act or Obamacare, or even healthcare marketplaces, they didn't know what I was really talking about as far as affordable means for health insurance. Anna is 21, and she's pregnant with her first child. Her fiancé is an undocumented resident as well. So she has fears about their future together because of this. She doesn't know what her husband being undocumented will mean for her in the future. She is 22 weeks pregnant, and at that point has not had any prenatal care. She's currently awaiting approval of her emergency Medicaid for pregnancy. So she's ultimately relied on what her mother and grandmother have told her about pregnancy to this point. The younger Rodriguez children, Matthew and Sarah, were born in the U.S. and they are U.S. citizens. They attend school and help on the farm during the summers. Matthew and Sarah have Medicaid, which was obtained because both of the children were in a car accident several years ago, which required hospitalization. The social worker at the hospital assisted their parents in enrolling them in Medicaid. Anna has established health care for both of them in a local pediatrician's office because she views preventative health care, as being a necessity in the United States. And so, since I said the Rodriguez family work on a dairy farm, this is how I was greeted as I approached their house. These are some of the cows that were out in the pasture that were staring me down as I drove in. So the last place that I visited in my fieldwork experience was Wilson Tree Nursery. Wilson Tree Nursery is different than early farms in that they do not use H-2A workers, they use contracted workers. So as far as contracted workers go, there is a supervisor. The supervisor is a legal citizen of the U.S. It's his responsibility to locate the workers for the season. He oversees the facilities. He deducts payments for wages, for room and board, and he runs the operations of the farm. The majority of the workers on the Wilson Tree Nursery are undocumented. Many of them, as he was telling me, come to the U.S. for less than 5 years, basically to make enough money for their families to live comfortably, and then they return to Mexico. Most of them do not speak English, although there are a few that do, and given my very limited Spanish-speaking abilities, I was able to communicate with a couple of them. The men that I met at the tree nursery ranged in age from 18 to 66. They did allow me to look at one of their homes, one of the trailers that they lived in, which were much different than what I had seen at Fernando's. in the Early's farm. The trailer was much older and it was in poor shape. Main observations that I saw included the appliances that were not working. The stove did not work. There was an insect problem. Mainly I noted ants and roaches. And the cabinets were bare. I did not see any food. And when I asked the men about that, they basically, at that point, said they had not had time to go shopping. These men have no security in their employment. Injury comes at their own risk. They do not have workman's compensation through a contracted worker. One of the men told me that it's been a couple years since there's been an injury on the Wilson Tree Farm, but he said that injury was a bad one. I was able to talk a few of the guys into telling me about their health and healthcare issues. Most of them had minimal, if any, health-based knowledge. None of them reported having primary care providers in Mexico or in the United States. And most said if they were sick, they would just go to the emergency room. It was interesting because I had two different gentlemen tell me that it's easier to slip through the system as far as documentation at larger hospitals, and so that's why they prefer to go to the emergency rooms. A few men report that they have families in Mexico that send them medications to them for personal use. These include blood pressure medicines, headache medications, and pain relief medications. And many of the men also report going to local Hispanic grocery stores to purchase prescription medications if they have an ailment that they think needs that. So for those men that were willing to talk with me and that I could communicate with, I offered some basic physical examinations to them as well. Hypertension was a major occurrence within the group. Other conditions observed were skin conditions, including I saw some dermatitis, some questionable skin cancers, and one gentleman who had diabetes who had foot ulcers. I also saw seasonal allergies and some musculoskeletal injuries related to overuse and sprains. Medication compliance is a significant concern to these workers who were prescribed medication. Issues voiced included the cost of the medicine, transportation to get the medicine, lack of understanding of what the medication is for, and then misconceptions of the disease or illness process. The other significant concern of the men that I interviewed was poor nutrition. All of the men cited that they eat McDonald's on a regular basis, at least 3 to 4 times a week, depending on when they had transportation. Many days at least one meal was missed, and health risk factors included smoking, alcohol, lack of seatbelt use, and poor hygiene. So based on my observations, I devised a list of topics for consideration and analysis. These topics were selected based on prevalence of occurrence and my perceived severity of the topic. Many of the themes had been discussed over the course of the semester and were reiterated by my experiences. As a result, most of what I saw was not a surprise to me. However, I will say that I was very surprised at the ability of many of the workers to purchase prescription medications with no prescription, and many of them probably not even knowing what they were taking. They would say they would go to the grocery store and tell them they had a head cold and come back with an antibiotic of some sort. So from the topics analyzed, I came up with a list of limitations and recommendations based on the migrant farm worker and Hispanic health care. Peer-reviewed journals were searched for literature-based recommendations to address these limitations, and these will be discussed. So communication was a big issue, and we've talked about that this semester, about how communication is the basis of all of our relationships. Thus, barriers to communication serve as a patient dissatisfier. It results in incorrect information, and it leads to unanswered questions because of the inability to communicate. This mainly in regards to Hispanic patients with non-Hispanic healthcare providers. 3 in 10 Latinos report having had a problem communicating with healthcare providers over the past year. 12% of Latinos report this as a major problem. Hispanics are twice as likely as Caucasians to leave a doctor's office with unasked and unanswered questions. So based on the literature that I searched, some recommendations. Mainly the Office of Civil Rights Policy Guidance states that it is our responsibility as healthcare providers to ensure language access to all of our patients. Many states are actually mandating provisions for language assistance services, whether that's through physical interpreters, telephone-based interpreters, or office-based bilingual staff. A lot of universities are now switching or moving towards certification of healthcare interpreters because this is such a national crisis that we have. And it's even gotten to the point where Medicaid and Medicare are reimbursing for language services. So you're getting financial assistance for this. And so I thought it was interesting, based on the literature search, the estimated cost of an interpreter is $279 a year per each patient, or $40 a session. And then for telephone-based program, it's $2.20 a minute. So those are just some options. You know, hiring staff that speak bilingual languages or having access to the telephone-based services are recommendations for improving the communication barriers experienced by Hispanic patients. The next limitation that I observed was trust and trust of healthcare providers. And I think this kind of goes hand in hand with communication, because if you can't communicate with your healthcare provider, how can you trust them? Because of cultural differences, trust is often a barrier to effective communication as well. It's a barrier to formation of relationships, and it's a barrier to open lines of communication. Hispanics are more likely than Caucasian patients to feel that a provider has judged them unfairly. Men generally report more mistrust than women, and mistrust or distrust is also associated with lower levels of income, lower levels of education, and lack of health insurance. So some of the recommendations based on the literature, and these are mainly for providers, is for providers to be more easily accessible, to have more flexible hours so that migrant workers are not missing work, which is often their lifeline to come to an appointment. So having nighttime clinics is a big patient satisfier for this population. Addressing comorbidities at each visit, it makes it more valuable for their time. Being perceived as credible, and that's just having, you know, culturally competent care, coming across as trusting and compassionate. Providing realistic referrals to other services. Most of these patients can't afford to go for, you know, laser eye surgery or gastric bypass or to go see a nutritionalist. So it's making the realistic referrals that are financially and feasibly possible for these individuals. Combining physical care with mental care. We've talked about some of the mental health issues and basically including those in your interactions. They recommend eliciting feedback from your clients and patients to make sure that your perceived receptiveness of your clients is what is actually being reported. And then, as previously mentioned in the last slide is having bilingual and compassionate staff members. One of the issues that I noticed with the Rodriguez family is that of mixed family status, or sin pious. And this is something that we haven't really talked about this semester, and so I thought that I would include it, just because I think it's going to become a more prevalent issue as time progresses with migrants, immigrants, and undocumented residents. So mixed family status is a family that is comprised of immigrant parents and at least one U.S. citizen child. Or more simply put, it's a family with multiple states of immigration. Currently, there's an estimated 2.3 million mixed families living in the U.S. And one of the major concerns of a mixed family is becoming a public charge. A public charge is an individual who is likely to become primarily dependent on the government for subsistence, as demonstrated by either the receipt of public cash assistance for income maintenance or institutionalization for long-term care at government expense. So that's big fancy words for saying immigrants who rely on WIC, food stamps, nursing home placement, those sort of things in which the government is paying for those services. Individuals seeking admission to the United States or seeking to adjust status to that of an individual lawfully admitted for permanent residence, which is a green card, is inadmissible if the individual at the time of application for admission has become a public charge. So this impacts the health care of children of immigrants negatively. So basically, undocumented parents fear that seeking assistance for their children may impact their status should they decide to become legalized citizens. So therefore, they don't seek care for their children because they think that care will be placed on their record. An additional fear of mixed families is deportation. And I found the statistic and it shocked me. But in 2012, an estimated 5,100 children of immigrants were in foster care because of parental detainment or deportation. And I'm sure since 2012, that number has probably grown substantially. So recommendations to address concerns of mixed family status based on the literature is mainly education and then further immigration reform. So basically with education, informing parents who are migrants or immigrants who have children who are U.S. citizens, just informing them that the children have rights as U.S. citizens to public assistance that will not impact their ability to attain their green card or citizenship should they decide at one time to become a citizen. So making sure that children get the health care and services that they need in the time that they need them. Misperceptions of health was a big theme that I saw with the workers that I interacted with. Health and what is considered healthy are variable from culture to culture. Understanding the various differences in what is considered good health is important to understanding the actions of those individuals. In the Latino culture, as we've talked about this semester, fatalism is a cultural belief. Fatalism suggests that an external locus of control controls a person's life. God's will impact the beliefs and the causes of disease, and thus potential actions to prevent or treat illnesses. So in regards to STIs and HIV, research indicates that Hispanics are either unaware or disagree with the latest CDC recommendations for routine HIV testing for all people aged 13 to 64 who live in high prevalence HIV areas. This misperception of risk has led to increased incidences of these communicable diseases in Latinos living in the U.S., and it's at a disproportionate rate to any other ethnic background. In regards to perceptions of weight, research has shown that Hispanics and African Americans are more likely to consider themselves at a normal weight when truly overweight than other ethnicities. This misperception increases risks of heart disease and diabetes, as well as metabolic syndrome because of excessive weight. A study conducted by Morgan, Park, and Cortez interviewed Hispanic women in regards to what they believed caused cervical cancer and breast cancer. Most Hispanic women interviewed stated that cancers were caused by bumps and bruises. And there's also a cultural difference in word use that I was unaware of. For example, the words disease and illness, which we interchangeably use in the U.S. Illnesses, as in the Latino culture, are often remedied through herbal preparations and healers. So thus a healthcare worker using the word illness may unknowingly be conveying incorrect information to the patient. And so recommendations are to use compassionate and culturally competent redirection and education as far as screenings, mental health, disease, and pathophysiology, to attempt to get patients to understand what we view as health. To discourage self-medication, that was a big one for the men that I saw during my experience, is the use of self-medication, and try to get them to understand why that is, to help prevent multi-resistant drug organisms. And then compromise medical treatment plan to include Western medicine and the complementary alternative medicines or herbal preparations that a lot of Hispanics tend to use. Another major limitation that I observed in the particular area that I live in is the lack of healthcare facilities and agencies for migrant farm workers. And we've discussed that in depth this semester. It's not only an issue in Guilford County, North Carolina, it's an issue nationwide and probably even worldwide. As evidenced by my fieldwork experience, despite living in a largely agricultural area, there is unfortunately no state or federally funded mobile clinics available in central North Carolina. For the migrants at the 3 locations that I was at, it's about an hour drive to Prospect Hill, North Carolina, which is where the Piedmont Migrant Farm Worker Agency is. And so if you think, that's 2 hours of driving plus your time there, that's a day of lost wages for these workers. So recommendations based on the literature search. There's several online agencies and organizations which provide great resources that can be printed off free of charge and used. The Migrant Clinicians Network, the website's provided there. They have a newsletter. They have links to where you can print off information in Spanish. They have an online newsletter as well. It's called Health Tips. There's some programs. It's a breast and cervical cancer evidence-based program that is used, and it's showing some great potential across the United States. One of the things that I did my literature search on was promotoras. Promotoras are a great resource that are up and coming in the United States, and they are basically community health workers who are trained either through educational institutions, through doctors' offices, or agencies like the North Carolina Farm Worker Project to provide health information, health education in Spanish to migrants, immigrants, undocumented residents to promote health and preventative services. There's a farm worker doula program to help with prenatal care, and then also just increasing public safety nets such as emergency systems that are in place, volunteer and church services, working on communication, having on-call volunteer interpreters available to communicate with patients when they come in. And then, as previously mentioned, legislative reform to give immigrants the services that they deserve and require. And then the last barrier that I was going to touch on was barriers to proper nutrition. So, as we talked about, food insecurity is a great concern for these patients and for the workers. I only saw evidence of this at the last site at Wilson Tree Farm when there was no food in the house. Barriers to and causes of food insecurity are availability and transportation. And then there's the knowledge deficit of what constitutes good nutrition. The workers at Wilson's couldn't tell me what was wrong with McDonald's. They couldn't tell me that it was deep fried and high in sodium. To them, it's easily accessible and it's cheap. So to them, it's good nutrition. And then another thing to consider is work pattern effects on meal patterns. The fact that these men go to work at sunup and come home at sunset often means that they're missing at least 1, if not 2 meals a day, on top of the fact that they may not even have food to eat. Early Farms provides Fernando and the other 2 workers with meals, but Wilson Tree Nursery does not provide food to their workers. And when they do provide food to the workers, it is taken out of their pay. So recommendations for this are focus group discussions on budgeting and preparation of meals, planning meals, thinking ahead for grocery shopping, providing information to migrants on community-based emergency food stores. This is like food banks, church-related services. And I found this cool program, East Coast Migrant Head Start Program, which is basically from, I think, Virginia to Florida. It's more of a focus on children's services, but there is family services as well, and it basically ensures that children are served at least 2 meals a day. They're in the schools. They do make farm visits. So I thought that was an interesting program to look into. So implications for future practice as a nurse practitioner, and what is the impact of what I've seen and done in this process of this presentation. The results have broadened my understanding of the disparities of migrants in Guilford County, North Carolina, as well as given me knowledge of common concerns, misconceptions, and needs for this population. I've learned that I need to work on speaking Spanish, and so that will probably start after graduation, with a focus on medical terminology. And then just seeing the vast needs of the areas in North Carolina that I have gone to, as well as that I know are across the state, is to consider giving back to the community through volunteer work with the North Carolina Farm Workers Project or other local agencies. And I know this is a significant need because when I talked to the outreach coordinator for Benson and told her that this was an observational experience, she politely told me that they do not allow observational experiences, that I would need to be able to provide some hands-on experience or support to them. And so when I told her that I was a nurse and that I was a student, she would be happy to have me then. Unfortunately, it didn't work out, but they're all too happy to have volunteers to help care for this population. And so here's my list of references for the literature cited evidence-based recommendations. And I hope that I've been able to share some information with you on the migrant farm workers in Guilford County, North Carolina.